Okay, welcome back, clinical problem solvers. Thanks so much for joining us today, no matter in the world where you are. Today is Monday VMR, and Austin and I are lucky to discuss again today. And really looking forward to another case by Vinny. He always seems to present us on these Mondays. And then, Anmalpreet is, I think, doing the teaching points, and Bayan's going to be doing the scribing. So really appreciate their hard work. And yeah, I think maybe Vinny, you can introduce yourself to everybody, and then we can maybe go ahead and get started on the first Alec.
Yeah, absolutely. Hey, everybody. Me and Gita, we are super excited for presenting another case, and let's see what we have for you guys. I'm ready. Okay, so starting with the first aliquot, we have a 67-year-old male that was transferred to our service due to pancytopenia. So initially, he reports progressive asthenia since 1 month ago, and it described it as if his bones and his legs were breaking. And these episodes were accompanied by headache, which led him to seek care at our hospital, and then was transferred to the floor. Additionally, he reports a history of schistosomiasis during childhood, which resulted in esophageal varices and thrombocytopenia. And he states that until 2023, his platelets remained between 90 and 100,000. And since then, he has noticed progressive worsening of his thrombocytopenia. Additionally, he was scheduled for an outpatient herniorrhaphy at the other hospital. However, 1 month ago, during the perioperative workup, laboratory tests revealed a worsening of his thrombocytopenia, and the surgery was contraindicated. And so other than that, the patient also reports 1 month of exertional dyspnea, denies any kind of chest pain or palpitations, and he has received one red blood cell back at admission, and denies any hematochezia, melena, gingival bleeding, epistaxis, and any other kind of bleeding or exteriorization. And also he denies any food restriction, no episodes of any ecchymosis, hematomas, and petechiae. I'll stop here. Let me know if you want any clarifications.
And sorry, I missed it, Vinny, but what was the procedure that he was slated to get and then was canceled?
He was about to be submitted to a hernia and see like inguinal hernia. Okay, get removed.
Perfect. Okay. Well, Alec, a rich start for usual of any cases. I guess since I'm talking, I'll just go ahead and take the first aliquot, or at least the first stab at the aliquot. Maybe I'll discuss parts of it, and then you can sort of layer in what you think or additional thoughts or things I don't get into or need clarification as the bigger brother. So basically, we have a rich background, but also foreground. And so I think when I was hearing about all these different things, we sort of have what the patient is telling us of the subjective aspect, and we also have an objective assessment already in the form of pancytopenia. So I think since I tend to see patients in the clinic where I don't have access to labs a lot of times compared to the hospital where they often come simultaneously, I'll kind of try to approach it from that perspective to start. And then I appreciate Alec layering it in. So when I hear these things together, I'm not going to know that the patient had pancytopenia. I'll probably know that the patient had a history of schistosomiasis complicated by what sounds like non-cirrhotic portal hypertension. But the thing that really struck me was the asthenia, but because that is such a non-specific complaint, it's hard to make progress on that alone. So really what stood out to me was this sort of profound bone pain in which the patient was describing that his bones were breaking. So how can we make progress on that? And I'm excited to reflect later because we had a recent sort of academy session on bone pain, and I haven't really committed the approach to memory yet, and so I'm excited to reflect on that. But really, when you think about the diffuse bone pain, you can break down the bone into its very basic structure. So is there something outside of the bone itself? So is there a periosteal problem? Is there a problem with the bone itself, like in the cortex, or is there something within the marrow? And so how can we start to make progress on those different hypotheses? From a periosteal standpoint, I think the time course could potentially be consistent with that, like over 1 month. And you could be thinking about certain infections or certain like exposures, in particular like medications or like heavy metals, for example. And so I suppose that could be potentially an etiology to go down, but I'm not really sure I make progress there. Within the bone itself, I think you'd be hard pressed to find a diffuse bone pain from fractures, which is what we initially think about with bone pain. So just to clarify with Vinny later, we can say, hey, is this really truly diffuse, or is it like just the legs or just the arms or something like that? So I think if we're in the space where all the bones are hurting, we think it's in the bone structure itself, then really we're thinking about what can diffusely affect structure of bone. And really that's like thinking about the components of bone itself. And really the one that comes to mind, statistically speaking, is just osteomalacia, which is usually related to vitamin D deficiency. So that's one thing that we'll definitely want to entertain. And then I probably work through like the other, less common causes of osteomalacia. But I think I'm already biased in my reasoning by the fact that pancytopenia exists, that there might be something going on within the marrow itself. And when you see the overlap of bone pain, diffuse bone pain, and pancytopenia, I think you have to anchor yourself within the marrow itself. And whether that's a primary problem with the marrow that is building up and then causing the pain, so it's like a crowded marrow from a leukemia, for example, or is that there is a secondary process of something infiltrating the marrow and then crowding things out and causing pain, and you're having pancytopenia as a consequence of that. Not that the cells are inherently abnormal, but that they're trying to work as best they can under very difficult work conditions, is I think what we're gonna have to tease out. So yeah, I'm hoping I'll definitely work to refine that approach more. But Alec, yeah, I would love your input on how you're putting everything together.
No, brilliant, Austin. I don't really have anything to add to that. I think I haven't committed the schema to memory either. I think the background history of likely non-cirrhotic portal hypertension is interesting. Just because as the splenomegaly potentially could get worse and worse, in theory, the other cell lines could get involved. Although it seems like it's something that has been quite chronic, and what the sort of more acute change, or if we find out there's actually a more subacute, tail to this, how that would play in, it is interesting. But the bone pain, I also found that extremely unique, and I really loved your approach there. And then just to sort of share, Robbie's approach to pancytopenia that others may not be familiar with. He comments on the 4 S's. I like to use 5. So S being sort of a stem cell problem, like a leukemia, like Austin was mentioning, systemic diseases like lupus, for example, a substance, either the presence or absence, so like B12 deficiency or the presence of alcohol, and then splenomegaly, and the last one being stuff. So as Austin was mentioning, something crowding out the bone marrow, like a primary cancer or an infection. So, the bone pain, yeah, really makes us think about what could diffusely affect the bone, either the periosteum, the bone marrow itself, or the structure of the bone, and other vitamins besides vitamin D. Could there be a collagen problem or a vitamin C deficiency or something else? But I think the depth of the other cytopenias is going to be interesting. And then, he does have exertional dyspnea, and while oftentimes dyspnea is something in the hospital they wouldn't really want to ignore, I'm more likely not going to be tracking this with the hemoglobin and seeing how he feels after the transfusion, because with the clinical syndrome, definitely could just be a great story for symptomatic anemia. So keeping that in the back pocket just to be sure there isn't a cardiopulmonary component to the disease, but certainly could just track with progressive cytopenias. And then the headache as well is interesting. It's fairly non-specific, of course. So I'll be looking for focality on exam, but does he just have a headache because he has pancytopenia and he feels crummy? Or because the head also has bone, is that also part of the process? Or does he have another primary CNS process, or like a CNS component to the systemic disease? And so it's really, really interesting here. And I don't have a lot of really experience with people that have suffered, non-cirrhotic portal hypertension from schistosomiasis, despite it being very common throughout the world. It isn't something that I commonly see here. So just tracking about how much of this would be expected, unexpected, and then sort of layering the bone pain in top of the pancytopenia, I think is going to be super fascinating. So Vinny and Julia would love to hear more.
So going on to the past medical history, he had a history of schistosomiasis since childhood, also esophageal gout, and hypothyroidism. From the habits and the night smoking, he's a former social drinker, about 2 beers on weekends, denies use of illicit drugs. From the social history, he's originally from the northeast region of Brazil and currently lives in the southeast. He previously worked in the metallurgical industry until last year with prolonged exposure to benzene, but has been unemployed for 1 year. Denies any recent travel, has allergy to tramadol, and current medications include propranolol and levothyroxine 125.
Yeah, and for just the beginning of the physical examination, let me show you. So he was afebrile, heart rate was 95, blood pressure was 120/80, respiratory rate was 18, saturating 92%, room air, and normal BMI. He was on a general regular appearance and general condition, markedly pale, 4 very, very pale, moderately dehydrated, 2 out of 4, and acyanotic, icteric, and afebrile. He was kind of alert, interactive, like Glasgow 15. And respiratory examination, there is no adventitious sounds, so vesicular breath sounds present. And he, like, due to he had a kind of in the upper limit of the respiratory rate, and he despite the fact that he was not with desaturation for comfort, they decided to put like just 1 liter of on nasal cannula. But other than that, cardiovascular examination, nothing remarkable. Abdominal, there is a spleen palpable 4 centimeters below of the left costal margin, non-tender. And this is splenomegaly is already consistent and previous with the other previous hospitalizations that the patient had. And extremities, no signs of edema or DVT. And I'll stop.
Okay, thanks so much, Julia and Vinny. So really rich here. So Austin, I'll sort of tackle the south west corner there, and then I'll maybe get some brief reflections on the exam before passing to you. So the schistosomiasis, it seems like it's been going on his whole life, and it seems like it's overall been stable. But I just lack the experience to know like how you would expect the disease to progress over time, if at all. So that would be something I'd be looking up in real time just to see if we would expect anything. But per Vinny and Julia, it seems like his splenomegaly and other things seem to be at baseline. And he has received some treatment with propranolol, which I presume just for variceal prophylaxis. But I'd love to know too if during this time, like he's had any bleeding. It sounds like not on the initial history, or how that's tracked, and if there's been ascites or other things that could be consistent with progression of that. The gout and the hypothyroidism, don't add too much to me. The gout, I guess I'd be curious at what age that was diagnosed. If that was something that was new, perhaps the elevated uric acid could be a sign of increased cell turnover and be a signal to the pancytopenia. But, it's such a common diagnosis, it's hard to know how much to put in that. The meds just to seem to track with the history. My geography with the country of Brazil is extremely limited, so I would be looking up what sort of infections and other things are endemic to those areas on the north and the southeast. I think you had said, so I'll have to lean on you guys for that since I have never been to Brazil. But his health-related behaviors don't really seem to contribute much as long as the tramadol. But his environmental exposure is really interesting. I don't know. I don't have too much experience with benzene exposure besides my time at the VA, and I do know it increases your risk of cancers. I believe hematologic more than solid, but Austin, correct me if I'm wrong. So that's something I was tracking, not to anchor on that, but just something I would be considering as an exposure. And whether or not benzene of itself could contribute to cytopenias is not something I'm aware of beyond sort of the realm of cancer. So I'd also be looking that up in real time. As far as his vital signs, his blood pressure is a little bit higher than I was expecting. For somebody that sounds like a significant degree of portal hypertension, but he doesn't have cirrhosis. And he is tachycardic on propranolol, which I'm presuming that he's taking. But it sounds like he's profoundly pale. And so this makes me think that his hemoglobin is extremely low, probably sub 7. We'll have to be keeping track of that to know if that's signal or noise. In addition to the mild hypoxemia, he doesn't necessarily meet criteria for oxygen per se, but he doesn't have an extensive smoking history or otherwise, and doesn't have clear parenchymal pathology on exam. But I'd be tracking, is this just in relation to profound anemia and would have to be very profound to cause hypoxemia? Or does he have some sort of pulmonary component to a cystic disease that we're going to have to track? In the splenomegaly, you guys are better at palpating the spleen than I am. So I believe all that. Definitely know the spleen is large and is contributing in some part to the cytopenias, but whether there's an acute or chronic insult here is what we're most concerned about. So that's be something that I'd be tracking as well. I would also love to know if there's anything on his skin, if he has any lymphadenopathy. And I think those were some of the other things that I was thinking about. But it seems like we're just getting a lot of signs that this is, acute, sort of heading to subacute, and trying to figure out what's going on there. And trying to figure out, is this a purely isolated sort of bone/bone marrow disease, or is there other systemic fingerprints here? We get signs of the head, signs of the cardiovascular system. I guess we're going to find out. So Austin, I'd love to know what your reflections are on.
Yeah, no, I think you covered everything really well. And Vinny, I was curious on your exam with the patient having kind of the diffuse bone pain. Was there anything that came up with that as far as like when you touched the patient's extremities? Was it very painful, or was it something that you weren't able to reproduce on the exam, something that the patient just shared with you?
Yeah, that's interesting, and thank you for the question. So no on physical exam, no pain on palpation, like no kind of any arthralgia, nothing remarkable. And regards the bone pain. And then when I asked for him to explain more about how he describes like this bone pain, and he'd say that he was kind of progressively weakening, like the weakness were progressing and progressing, and like the strength in the legs were decreasing. So I think that when he described the sensation, it were more related to the weakness than the bone pain per se. And I'm very confident when I interviewed him that that was not a like generalized bone pain.
Okay, yeah. So it seems like maybe it's not signal. It's just that the way the patient was describing his symptoms was that he was experiencing such like profound decline in his functional status that he was describing it as like he was breaking his bones, but it wasn't that necessarily. It was a pain predominant syndrome. Am I understanding correctly?
Yeah, that's correct.
Okay. All right. So good. I think some of the reflections I was going to have then I will table. Just to mention them in passing is that hypothyroidism can cause periosteal disease, and then some of the heavy metal or like exposure history that was rich can certainly predispose to sort of like diffuse bony disease, as we were talking about before, as well as cancers, as Alec alluded to. But again, Vinny provided a nice clarification, so I'm not sure that I will take that any further at this moment in time. So yeah, Alec, I think you're bringing up a good point that you mentioned. Like, what is the time course of this disease? We're hearing that it's a month, but for him to get a anemia severe enough to require a blood transfusion is and then no overt signs of bleeding. I'm with a big caveat that the most common cause of bleeding that people say that they're not bleeding is that you just are bleeding and you can't see it, and it can be slow and indolent. So it suggests that there's probably a lot more chronicity to this problem than 1 month. I'm wondering if you think that there's anything else in the patient's history or presentation that might make us rethink the time course a little bit. Because if the patient is truly anemic, like went from fine hemoglobin to transfusion threshold hemoglobin in a month without overt bleeding, it seems a bit improbable to me. But again, that's not something I would routinely see. But people can bleed slowly for months, years before the hemoglobin drops down that low. So if you really went from like 14 to 6 in a month, then that would imply to me that probably the patient is not bleeding and there's another mechanism. I'm not sure what your reflections are on that.
No, I agree. It can be really difficult. And oftentimes we'll have a combination of everything. It sounds like maybe, maybe they were bleeding a little bit, had some, vitamin deficiencies, and then like got a second insult on top of that and really couldn't compensate. But yeah, microscopic bleeding is something we're still going to have to exonerate, of course. But the sort of the pancytopenia and trying to define the time course of knowing, like, when did we last know that the patient's labs were normal, right? Well, maybe they were just checked a year ago, and so like he felt bad over the last month, but that doesn't mean the disease started a month ago. And so, I think the pseudo-acute, more like this is actually subacute, the time course becomes very interesting. But I think hopefully some of the initial diagnostics will give us some clues to how long this disease has truly been going on, and whether it's truly isolated to the bone marrow or systemic as well. So, yeah, love to hear more from you both.
All right, yeah. So going for the CBC hemoglobin and animation of 4.4, hematocrit of 12.4, the VCM of 110, RDW of 20, the HCM of 40, which is increased. The platelets 13,000, the WBC of 910 without differential, because in the machine, due to the low count of the leukocytes, they couldn't, the machine couldn't see the appropriate differential. But I'll give you some other labs in the future. And the reticulocyte count, it's decreased of 0.3. The PT is 15, which is normal. The INR is 1.38, which is slightly increased, and it is compatible with the patient's baseline from more than 3 years ago. The TTPA is 27, which is normal. The fibrinogen is 99. Urea, I have the urea here, and I will do the calculation for the BUN for you guys. So give me 1 minute. And the creatinine is 1.3, which is also compatible with the patient's baseline. The glomerular filtration rate is around 60. The albumin is decreased at 3.1. Sodium is 130, which is compatible with the patient's baseline. Potassium of 4.2, magnesium of 1.4, bilirubin, total bilirubin 2.4, being the direct of 0.7 and the indirect of 1.7. Yeah, I think that's enough, and then I'll give you more labs.
Okay, yeah. So I think, Alec, it's my turn, right? Okay, yes. So I think we've confirmed, what Vinny told us from the very beginning, of the patient has like a very dense pancytopenia. And, in the background of a patient's known liver disease, there doesn't really seem to be anything truly striking on the labs, like outside of the CBC itself. It'd be curious to know if the sort of mild hyperbilirubinemia that seems to be indirect predominant is a new issue or not. And this becomes relevant because I think the main finding on the pancytopenia is that the patient has macrocytosis. And this will also be good to provide clarity if it's like new or not, because I suppose if the patient has chronic liver disease, then you could have macrocytosis. And then if we don't have a TSH, we should update that. Though again, TSH in my experience, or like hypothyroidism, is rarely a cause of macrocytosis, though it is a part of the evaluation. So then I think now we're going through the causes of macrocytic anemia plus pancytopenia and overlapping those things. So what causes macrocytosis? I think at its core, either, initially you're trying to put out a bunch of cells that haven't had time to develop. And so that's where you get the reticulocytosis. But in this context, and from the labs that Vinny already shared, that doesn't seem to be the case. So then basically you're having impaired sort of production or differentiation of cells within the marrow, so that they remain big. That's like my very simplistic way of thinking about it. So what are the causes of that? So I think from a vitamin deficiency standpoint, we'd be thinking about B12 and folate. So we'd definitely be exploring that. Seems like the patient's diet, as far as we can tell, is okay. So probably folate deficiency is less likely, but B12 can definitely sneak up on you for sure. So we'd want to clarify that. And then I also honestly forget about all the parasites, etc. I believe it's a different parasite that causes the low B12, but I would clarify that situation. The other things that can do it, so copper deficiency, zinc deficiency, those would definitely cross our minds as well. We'd have to think about hemolysis in like the form of autoimmune hemolytic anemia, for example. But again, I think with how hectic this patient's CBC looks, I'll be a bit surprised by that unless this pancytopenia is also a reflection of like an autoimmune or sort of other inflammatory condition like certain cancers that could cause this. So I'm not getting the flavor of that at this moment in time because we haven't found anything else on her exam and our labs thus far. We'll be curious to see though. We definitely be wanting to get a smear to try to understand what's coming out of the marrow as much as possible. So I'd be excited to hear what that shows. Other than that, I'm sure I'm forgetting a few of them, but really I think about exposures. So ethanol, for example, we haven't heard anything about. Liver disease, we already know the patient has. Vitamin deficiencies, we're going to explore. Hemolysis, we're going to entertain, of which we'll make progress on that, and other issues in the marrow with the smear. And then if and then speaking to that, if all of our sort of initial evaluation comes back negative, then we'll be thinking about the possibility of MDS or something that lives on that spectrum of a disorder. So yeah, that's how I'm kind of thinking through things right now. Alec, what else did I miss?
No, that was awesome. Yeah. So I mean, just the breadth of the sort of thrombocytopenia, the pancytopenia here is striking. I think the MCV could just point to a sick marrow, or the marrow is trying to produce, put out early precursors because the cells are being destroyed, or they can't make, fully competent ones or fully matured ones. I think the things that struck me as curious were the INR. It is mildly elevated, and the fibrinogen is quite low. So we know that the patient has presumed non-cirrhotic portal hypertension. So in theory, synthetic function should be okay. So is this a sign that perhaps like there is some liver involvement that we were not previously aware of, and the patient could have cirrhosis, for example? Or is this a clue that the patient has some mild vitamin K deficiency or has some DIC, either acute or chronic, of so the severity of which is a little bit less clear. But I agree, the smear is going to be the most important test here. Like, are we seeing blasts, right? Are we seeing schistocytes? Right? We really need to rule out, are we seeing a bunch of spherocytes? We need to figure out, are we seeing, leukoerythroblastosis, right? We need to figure out what's going on inside the marrow, because with how profound the pancytopenia is, it makes it hard to think that there's not something going on in there. But it certainly will exonerate everything else. And then the indirect hyperbilirubinemia, just points to, extravascular hemolysis primarily. And we know the spleen is big and is probably consuming some of that. But also we can rule out, intravascular as well. And so I think, getting a haptoglobin would be helpful. And I think because of, primary bone marrow processes are on the differential, whether that's like a primary leukemia or that's intramedullary hemolysis from B12 deficiency, right? A smear is going to be super helpful. And then an LDH, I think, would also be quite useful here as well, just to see how high it is. And then a uric acid as well, just to see. I don't know if it's going to change anything acutely, but might sort of further raise the spidey senses that there's something, a primary problem here in the bone marrow, particularly with its exposure to the benzene. Mark always talks about this, the retic, like in the inpatient setting, it's pretty much always low. So it's, maybe he's not having such brisk hemolysis, and certainly doesn't point to an acute process, right? Definitely makes me think that there's a little bit more of a hyperacute process, more of a, acute to subacute tail. So I think it is quite peculiar. I guess I was a little bit surprised by the sort of the depth of the both fibrinogen and whether or not there is a sign of DIC or perhaps liver disease that has a little bit less characterized. It's just something to think about. But I think the smear is kind of going to be where the money is at here, and trying to figure out, like, again, do we need to kind of go for the bone marrow, or are we going to start seeing clues elsewhere that there is an extra sort of medullary component to this disease with some of the other things? Because we haven't really defined further the, the dyspnea, which again, presume is likely from the anemia, right? Or these headaches, or this sort of weakness that has been either otherwise not described, or whether this is actually bone pain or not. So yeah, I guess those are my thoughts. Anything else, Austin, before we sort of pass it back to Vinny?
Just reflecting on the macrocytosis again, and like, if we haven't had an HIV test, we'll probably want one of those. And then the sometimes with myeloma, you can see the SPEP, or sometimes with myeloma, you can see macrocytosis through like an interesting cytokine mechanism. But we're not really getting any other features of that, at least at this moment in time. But those are the only two other thoughts that kind of round out everything else. So what else happened next, Vinny?
Yeah, amazing. So now I will share this meter. Yeah. I will leave 30 seconds for this picture.
30 seconds is 30 seconds too long for me to understand what's happening here. But yes, no, this is amazing that you got these. Thanks so much for sharing. And I will do my darndest to try to understand what's happening here.
And
Yeah, Austin, you just want to go for it together? I feel like I'm seeing like maybe some schistocytes, but it's like I see some, especially in the middle sample, kind of got like a half-eaten one with a little bit of like a sort of wave at the bottom. It's like kind of looks like a helmet. That could be a sign of schistocytes. And not seeing a lot of the white cells, so that's hard to know. They don't look like flank spherocytes to me. But what are you saying, Austin?
Yeah, I think I'm seeing exactly what you're seeing. I'm seeing what looks like schistocytes. We're not seeing like spherocytes as just autoimmune hemolytic anemia, to your point. We're seeing like sort of the pallor within the center of the cells, which can be a clue to sort of like normality, so to speak. And there's some other sort of fragmented forms, but really the ones that stick out to me are some schistocytes. And then I think the lack of white cells and platelets is just a reflection of the depth of the patient's pancytopenia. And so even though the hemoglobin is markedly low, the red blood cell count is just statistically like so much higher than the other ones, that's why that's what you're seeing the majority of. But that's the best I got. I'm not seeing like,
I don't know if there's someone in the middle that looks like Thierry, but it's hard to say for sure to me as a non-hematologist.
Yeah, that's the only thing I was trying to pay attention to is there any sort of dacrocytes? But yeah, I can't. I don't. I can't feel confident in that. So yeah, Vinny, what did they find?
yeah, all right. And now I'll read what they found here. Give me 1 sec. Yeah, so the read is in the red cell line, moderate anisocytosis, abundant ovelocytes and dacrocytes, 2 to 4 schistocytes per feud. Platelet line, severe thrombocytopenia, no platelet clumping observed, and a white cell line, marked leukopenia with neutrophils showing 4 to 5 lobes, typical lymphocytes, no immature cells observed in any field. I couldn't see those white cell lines, but anyways, yeah. And if talking a little bit further with other labs, the AST is 232, ALT is 106, GGT is 75, alkaline phosphatase of 79, the LDH is 6,000, and the iron is 51, which is normal. The ferritin is 800, and HIV, the word asked also. So HIV negative, hepatitis C, hepatitis B, both negative. Dengue PCR also negative. So yeah, that's it. I think that's a good place to stop.
Thanks so much, Vinny. Just to clarify with you and Julia, how many more aliquots until the final diagnosis?
Yeah, I have one more aliquot and then I'll reveal the diagnosis.
Okay, awesome. Thanks so much. Awesome. I don't know whose turn it is. Is it mine or yours? Okay. So yeah, the smear, at least Austin and I got like half, I don't know, half of it right, but basically looks the bone marrow is unhappy. And so the AST greater than ALT, I don't, the GGT is normal, but the AST predominant, could this be liver disease? Potentially, but that could also be a sign of hemolysis. And the schistocytes on the smear are definitely concerning for that. And the LDH of 6,000 is profound. So I guess I'd love to know, the haptoglobin just to confirm that there's some component of intravascular hemolysis, but the ferritin being high with the iron being normal makes me think that probably there is, because some of that iron that's in the blood is from, from the cells lysing. So I guess the question is, what would be the cause of that? And I think Vinny said on the smear that they noticed some sort of hypersegmented neutrophils. And I guess he can correct me if I'm wrong, but that in combination with the profound elevation of the LDH and the signs of, some, bone marrow breakdown definitely makes me worried about B12 deficiency and intramedullary hemolysis, and could play into some of that. Definitely, I would definitely be sort of looking at the smear again, though, to try and look at the white cells very closely to be sure we're not missing acute leukemia, to be sure there aren't any blasts or anything. But I'd be very curious to see what the B12 is, and if we have access to an MMA, I think that would be very helpful as well, potentially informative. But the LDH being so striking is something that I've seen mostly in intramedullary hemolysis. And then, whether or not if we need to figure out there is something else in the bone marrow that's, crowding it out and pushing the cells out, to like a metastatic solid cancer. We have no really extra bone marrow signature to this disease. Primarily, it seems to be all sort of inside the bone marrow, which makes me think like a primary solid cancer, which we worry about. It would be a little bit less likely, certainly not excluded. But those are sort of some of the things that I would be thinking about. So, to go from there, I think I would just be, and then I guess the schistocytes too with the LDH and with the fibrinogen definitely makes me think about DIC and also, and just being sure we're excluding cause of that. So in short, basically, I'm very worried about the patient could have B12 deficiency it's causing this, and we could just empirically replace until we get the level back. I don't know how long it takes at your hospital. Then the question would be why? And we would have to investigate that further. Do they have pernicious anemia? I don't see any medications that could be culprit, not a metformin or anything like that. Really, we still need to exonerate a primary bone marrow process, primarily in leukemia. And so I would need to figure out if, we feel comfortable with the smear or whether or not we need to go for, flow cytometry plus minus a bone marrow biopsy. But those are some of my initial reflections. Austin, I'd love to know what you were thinking about that.
Yeah, I think you've captured all the key points, but I think it's unique to see hemolysis with a low reticulocyte count. And so I think if you're in that space, and then that makes you think of B12. And then when you see an LDH of 6,000 plus a bilirubin, that's very underwhelming. But a hemoglobin that's dramatically low. And again, I think that is also unique to this sort of pseudo MAHA that happens with B12 deficiency. I think the trap of this case is, this patient's B12 could very well be normal or even high. And that is reflected in the patient's sort of liver disease itself. And so this is where utilizing the other testing for understanding someone's B12 status is really important, and where the MMA is, I think, particularly helpful. And then there's another test, but it's not widely used, so I won't discuss it. But I think I have been in this space before and seen normal B12s, and people get missed for some time. So I think the next test will be a B12 plus an MMA if possible, or empiric treatment, as Alec alluded to. As far as the etiology of this patient's symptoms, I think at 67 years old, unless they adopted veganism relatively in the last few years, or there's some other parasite that the patient has acquired, or there's something about the patient's exposure to chemicals that I'm not understanding as far as B12 metabolism, then statistically speaking, probably the patient has pernicious anemia. And then to your point about not missing a hematologic malignancy, the unique thing about B12 is that including some vitamin deficiencies, it causes such dysregulated cell production and turnover that for all get out, it can look like the patient has a malignancy or a cancer. And there's even been cases of people getting treatment for blood cancers, but it was all just related to B12 or copper deficiency. I think Kirtan presented a case about that maybe a year or so ago. So I think you'd be hard pressed to do anything dramatic until you gave the patient B12. Yeah, very great. Vinny, what do you have for us?
Yeah, okay, so just for the final aliquot last piece of data, the TSH is 4, which is normal with a TL4, T4 of 133, which is normal. The vitamin B12 is decreased at 117. And then the B9 folic acid was 12. Yeah, I'll stop here.
Okay, well, it looks like they're low. And so I think, we would replace and then try to understand why this patient developed this condition, had this predisposition. But as we discussed before, I think unless we go back and take a good dietary history, make sure there's no other features of malabsorption, and otherwise probably send the testing for pernicious anemia. Alec, what other thoughts do you have?
No, I love that. And, just reflecting, the patient already has one autoimmune disease with hypothyroidism. So certainly could be at risk to have another with pernicious anemia or autoimmune polycythemia syndrome or something like that. I think Austin and I discussed a case from Cheshire maybe, or I can't even remember, a long time ago, about that. But yeah, I think the fibrinogen, I just haven't checked the patients I've had with intraventricular hemolysis from B12 deficiency. I haven't checked a lot of fibrinogens. And the INR being elevated, I think I would probably just repeat it. And then if it persistently elevated, I guess just do a mixing study just to be sure the patient doesn't have vitamin K deficiency or something. Because I imagine with all those cells being destroyed, that the fibrinogen being low makes a little bit of sense. But if the coagulopathy persists, definitely would have to be thinking about whether or not he has more liver disease than we realize, or if there's another process that's driving this. But it's hard not to, like you astutely noted, Austin, with the sort of profound LDH elevation and sort of hemolysis we're seeing on the labs in the smear, but with a very underwhelming retic that this is, and then the hypersegmented neutrophils on the smear as well, like that this isn't B12 deficiency, but definitely would want to be sure that we're not missing anything. So I think depending on your resource settings, empirically treat, would sort of monitor the counts and see how things are going, and then I think things aren't improving as expected, or the markers aren't improving as well, then whether or not a bone marrow biopsy or other investigation would be worthwhile would be a consideration. But yeah, what do you think, Austin? Anything else to add before Vinny and Julia can tell us what's going on?
Well, I think we'll just reflect on that. We have not mentioned TTP a single time. I think if you're in the space of deep anemia, thrombocytopenia, it would be appropriate to mention that. But there's so many features that go against TTP that we didn't even mention it. And this is why, one of the features of I think it's the plasmic score, is the MCV, because it's such a powerful clue that it's not TTP. And so, the LDH elevation is something that can be striking and TTP related actually to, I believe, muscle ischemia, which is a nice tutorial from Tony Brew from a couple years ago, if I recall. But yeah, I think I'd be remiss to say that the reason we didn't mention TTP is some of the other features that we already outlined, but you would absolutely not be wrong to be considering that in these circumstances. So
we said
right.
TMA. We said TMA.
You said TMA, but you didn't mention TTP explicitly, which matters from a management standpoint. But yeah, all right, Vinny, what you got?
Yeah, so that's a case of pseudo TMA secondary to vitamin B12 deficiency. And when we are discussing about the possible etiologies, like before we know in the low B12, we discussed it like just the patient that having the headache. We consider both the TTP, and we were less concerned about other blood cell dyscrasias, and the patient didn't refer at any time arthralgias or like any kind of petechiae or any blood sign in the skin or yeah, any kind of that. So and then when the MCV came, we tried to narrow down the diagnosis, and besides considering the like APLS and myelodysplastic syndromes and other stuff, and it was me and the hemonc fellow that were seeing the case, and then we could see and try to differentiate between those things. And due to the very low cell count in the CBC, we also consider an invasion of the medulla by the schistosoma. But due to no very signs suggestive of portal hypertension and due to the lung curve, so we thought that these would be very unlikely. And other than that, we strongly strongly consider to just empirically treat and see how the B12 will go back. And the patient answered like responded super well to the treatment. His reticulocyte count came from 0.3 to 10%. So that was impressive. I haven't seen a case like that before. And we answering Mark's question and the possibility of TAP, that was a strongly suggestion, also due to a possible secondary thing or superimpose it on the top of the pseudo-TMA. But as the patient responded to the treatment and was like the hemoglobin was increasing and all this stuff, they didn't proceed with the bone marrow biopsy. But yeah, if you guys know anything about that, I would be curious, because I don't know how we can go or proceed with the biopsy in this case, if that would be a good suggestion or not. Besides the fact that we were very concerned, because I never saw a so severe vitamin B12 deficient like that. But I don't have like clinical practice. So have you guys had the opportunity to see anything like that before?
Yeah, I mean, I've seen a few cases of pseudo TMA from B12 deficiency. I don't know if any of them I've ever checked a fibrinogen though. But I think time and sort of empiric treatment are some of the best diagnostic tests. So if the patient's cytopenia is improved, most people with acute leukemia are going to declare themselves. So if his cytopenias are improving, he is otherwise doing well, and his sort of markers of hemolysis, and then if you repeated the sort of DIC markers in the smear, things are getting better. I feel like I would feel fairly confident with diagnosis with ongoing sort of close monitoring. But I think you definitely would need to watch vigilantly to be sure that the patient is improving as expected. And if not, then you would really need to consider doing a bone marrow. But besides that one feature, I feel like the case is fairly consistent with the pseudo TMA and sort of intramedullary hemolysis from B12 deficiency. Just in my limited experience, my N of like 3 or so. But yeah, I would also love to know like why you thought the patient was so profoundly B12 deficient, and whether or not you thought there was other workup that you guys were going to pursue because of that.
Yeah, just one quick thing else, and like, and regards the etiology, I forgot to mention the patient had an AGD from a couple of years ago that showed signs of atrophic gastritis, and we couldn't ask for the antiparietal and the other antibodies that would confirm the pernicious anemia. But the etiology was likely due to atrophic gastritis and also regards the age that was compatible. So that's all. Thank you.
Yeah, thanks so much for the case. And no, it's amazing to think like, this patient is feeling like this patient has a hemoglobin of 4 and platelets of nothing and a white count of, 900. And there's no fever, there's no signs of inflammation, there's no nothing. And so I think if you reflect on that aspect, I think that will take you pretty far. And as Alec had mentioned, I think others had mentioned in the chat, if this was malignancy of some kind, like most likely would have declared itself one way or another in the form of an infection or tumor lysis syndrome or something in that regard. So I think the lack of sort of hecticness outside of the CBC abnormality itself is a clue that probably there's not too much else going on. I think the B12 can humble in many ways, though. It can present, it's very protein in its manifestation. So I wouldn't exclude the possibility of something else. But as Alex said, I think if you just ignore the fibrinogen, like, I don't know, I think that the thought was like, okay, maybe there's DIC or something like that. But like, if you just ignore the fibrinogen, like mild LNR elevation, I think in this context, like I was sort of disregarding it as noise entirely, which just may have been just error, but I didn't even include it in my reasoning at all because I just didn't think it really mattered. And then, yeah, I think the lack of response to B12 or improvement of those things would have clued me in to say, hey, maybe I need to investigate this further. But I think the story was overwhelmingly consistent with B12 deficiency that probably wouldn't have invested too much cognitive energy into sort of like the mild fibrinogen and INR derangement. But yeah, okay. Any final reflections, Vinny, before we pass the mic to Anmol? No, all right. Take us away.
Thank you for the great case, Vinny, and a wonderful discussion, Dr. Austin and Dr. Alec. I'm sorry I'm joining from the office, so my laptop just shut out, and I'm just going to give the teaching points from my phone. So we'll go through a little bit of them. Initially, the patient came to us with the complaint of bone pain. So we were thinking that we know the objective of pancytopenia, but we should think about a subjective symptoms first and analyze it. So we focused on bone pain because an asthenia is a non-specific symptom. So when we think about bone pain, we can think something affecting the periosteum, or within the bone, we can think something affecting the cortex or bone marrow. So we were thinking about the differentials like hypothyroidism, infections, heavy metals, or fracture. But fracture is the localized bone pain. It's not diffuse. So diffuse bone pain, we think about osteomalacia, which can be due to vitamin D deficiency. And then now we can associate the objective, that is pancytopenia, with the subjective symptoms. So we can think that probably the problem is with the marrow that can manifest as bone pain and pancytopenia both. But then Vinny clarified that it was more of like a weakness or asthenia. That was a predominant symptom. Then we considered some differential about pancytopenia, which could be a problem with the bone marrow or a bone marrow problem. Either it could be infiltration or bone marrow failure, versus there is some peripheral destruction. And we discussed about the 4S or 5S, that there could be something related to the stem cell or a systemic disease like lupus, which can present with pancytopenia, a substance, alcohol, and splenomegaly. So whenever we have pancytopenia, we need to know the baseline levels to ascertain the time course of the disease, if it is acute, subacute, or chronic. Then we had deep pancytopenia in the labs. We realized that hemoglobin was 4.4. Everything was very low. So we with that, we need to get a retic count or a peripheral blood smear to look for blasts, cystocytes, or spherocytes, which can guide us to the diagnosis for the patient. And exertional dyspnea was likely secondary to anemia in this case. And then we had an amazing point about macrocytic anemia with pancytopenia, which could be number one, good macrocytic anemia, good macrocytosis, or that is called reticulocytosis, in which immature cells are released into the blood. But the retic count revealed something else. So we thought that there could be impaired differentiation of cells in the bone marrow, which can be due to vitamin deficiency like B12 and folate, leading to ineffective erythropoiesis. Then some medications can also lead to that. copper deficiency, zinc deficiency are some of the other causes. And then liver disease and hypothyroidism are some of the metabolic causes contributing to that. Alcohol and MDS are the other causes. And we also discussed about HIV and myeloma. So we were in that spectrum of considering the differentials for macrocytic anemia and pancytopenia. So we thought that the patient had indirect hyperbilirubinemia, which indicates extravascular hemolysis. We thought of getting a haptoglobin and LDH to see the intravascular hemolysis component too. Then we realized the patient was having coagulopathy, that is elevated INR with decreased fibrinogen, which made us concerned about a severe liver disease, which has now progressed to cirrhosis or acute versus chronic DIC. And then there was a great point in the chat about pancytopenia in older adults with DIC physiology. We can think about APML. And then we had hypersegmented neutrophils in the smear. So that definitely raises the concern of vitamin B12 deficiency, and we have to rule that out first before going ahead. And then we saw the elevated LDH in 6,000 range. So that could be because of destruction of cells, and that can be acute versus chronic. Chronic can be in sickle cell anemia and other causes. So then we discussed that now, since we are the very much sure that it could be vitamin B12 deficiency, what could be the tests we can use to test that? In vitamin B12 deficiency, we can have normal serum levels. So it's important to get a methylmalonic acid to actually rule out vitamin B12 deficiency. And then if we find that he is vitamin B12 deficient, then what are the causes for that? So a dietary history will help, and we can test for malabsorption. Also, the history of previous autoimmune disease raised concern for a possible pernicious anemia in this case. And then finally, the teaching point was about if we have such a picture in the patient, before aggressively treating for a tumor, it's better to give empiric vitamin B12 to the patient, which can actually save the patient from some harmful treatment measures. And ultimately, the diagnosis was vitamin B12 deficiency, leading to pseudo-MAHA picture or pseudo-TMA. Thank you so much. It was a great case. Lots of learning.
Awesome job. I'm all pleased with the teaching points as always for our work as well. So thanks for doing that. The reflection, yeah, I mean, just a great case. And vitamins can affect many things, cause many different symptoms, and in this case, more hematologic based diagnosis. But Vinny, awesome job. The only thing that could have made this better was if you wore those glasses, and that's pretty much it. So I appreciate it. Hope everybody has an amazing day, and thanks again for Bayan and Anmol and Vinny and Julia and Austin. Take care, everyone. Bye bye.